Good afternoon, and we want to welcome you to this e-seminar on IgA nephropathy and novel treatments. And this e-seminar is organized by the Immunonephrology Working Group of the ERA. For this seminar, there will be a real-time translation. ERA is launching a real-time translation in 7 languages: French, German, Italian, Portuguese, Russian, and Spanish and Turkish. To enable the audio, click on the globe icon at the bottom near the polls function and choose your language. For the captions, an external link to access through the browser will be provided within the chat. Credits will be given for this e-seminar for the live participants, and they will earn 1 European credit for the continuous medical education. This is an exclusive benefit for active ERA members only. To get the diploma, attendees must fill in the mandatory questionnaire feedback at the end of the e-seminar. So with no further ado, I want to introduce our speaker of today, Jonathan Barrat. He's a professor of renal medicine at the University of Leicester. He's a very well-known expert on IgA nephropathy and lead or chief investigator for a number of randomized controlled trials in IgA nephropathy, both phase 2 and phase 3 trials. And then we have Claudia Seikrit, who's a nephrologist from University of Aachen in Germany, with the focus of IgA nephropathy. And finally, an important member of the Immunonephrology Working Group, Gema Fernandez Suarez, who's a nephrologist at the University Hospital of La Paz in Madrid, Spain, and an active member of the Spanish GLOSEN group. Professor Barrat couldn't join us today live, so we will start with his talk that is recorded. If you have any questions, please use the Q&A box for that.
Hello, I'm Professor Jonathan Barrat from the University of Leicester in the UK, and it's a real pleasure to join you for this ERA seminar on IgA nephropathy and novel treatments. I'm sorry I can't be with you live, but I know there's going to be some great discussion after my talk, and I want to be a little bit provocative and see whether we can really explore where we think IgA nephropathy treatment may go over the next 5 to 10 years. So I'm going to turn my camera off now, not to distract from the slides, and we'll get cracking. So here are my disclosures. So IgA nephropathy was first described in 1968 by Jean Berger when he was able to stain kidney biopsies for IgA deposition, and he identified the disease we now know as IgA nephropathy. So the disease is now 56 years old, but over the last 56 years it's become recognized that this disease is the most common form of primary glomerulonephritis in the world. It's estimated that of all those patients on dialysis across the globe, 1 in 10 of them is on dialysis because of IgA nephropathy. Now that's heavily driven by the incidence and severity of the disease in East and Southeast Asia, and certainly not what we see in Western countries. But globally, IgA nephropathy is a significant cause of kidney failure, particularly in young adults. And I'll talk about the risk of kidney failure from some data we've generated in the United Kingdom. We know that if patients do end up with kidney failure and are fortunate enough to get a kidney transplant, there is a real risk that this disease will recur, and there is a significant chance that this may be associated with graft dysfunction and even graft loss. Here are the estimated prevalences of IgA nephropathy across the globe, and these are likely to be an underestimate because IgA nephropathy can only be diagnosed with a kidney biopsy, and therefore any epidemiological figures are heavily influenced by accessibility and affordability of kidney biopsy, but also by the threshold for individual nephrologists to perform a kidney biopsy. And this heavily influences IgA nephropathy incidence rates, particularly in those countries that do not have easy access to either primary healthcare or nephrology services. So this is the data I was talking about. This is data from the UK Rare Kidney Disease Registry, RaDaR. It's a registry that has over 28 different rare diseases and over 30,000 adults and children with rare kidney diseases. To be eligible to be consented into the IgA nephropathy rare disease group, patients need to have at any time in their natural history more than half a gram per day of proteinuria or an eGFR less than 60 mils per minute. So in essence, that means anyone that we are likely to diagnose with IgA nephropathy in modern times. It doesn't, of course, include those patients who only have isolated non-visible hematuria. But to be honest, we don't biopsy those patients anymore, and therefore they don't get a diagnosis of IgA nephropathy. So if we look at outcomes, if we look first at overall outcome, you can see here that at 20 years following diagnosis, if you're a child diagnosed with IgA nephropathy in the UK, half of those children have developed kidney failure at 20 years. If you're an adult, 3/4 of those adults have developed kidney failure 20 years from diagnosis. And if we look here at the age of diagnosis or the age of kidney biopsy, for a child diagnosed with IgA nephropathy, by the time they reach my age, so 55 years of age, over 3/4 of those children have developed kidney failure. If you're diagnosed with IgA nephropathy in the UK between the ages of 18 and 40 years of age, 2/3 of those adults have developed kidney failure by the time they're my age. And if they're diagnosed between the ages of 40 and 50 years, then half of those adults have developed kidney failure by the time they're 55. And I don't think 55 is a particularly old age. And therefore, I think it's a disaster, to be quite honest, if you're diagnosed with kidney failure in your mid-50s, even if it's 20 years after your diagnosis, it is still a disaster. People in their mid-50s still have a fantastic quality of life. And actually, we should be striving to prevent kidney failure in the lifetime of our patients. What we did here was simply take the GFR on the day of kidney biopsy for all the patients in RaDaR, and we just said, what would the rate of loss of kidney function need to be for the rest of that person's life to avoid kidney failure in their lifetime? And so here you can see, for those diagnosed with between 18 and 30 years of age, we took their real GFR at the time of diagnosis, and what you can see is unless we get down to a rate of loss of kidney function every year for the rest of their life of 1 mil per minute per year, we are making little headway in terms of the proportion of patients who will develop kidney failure in their lifetime. And indeed, this is the same across all age groups. And what this is telling us is that this is a disease of young people who are already presenting with established chronic kidney disease with significant nephron loss. And therefore, if you're presenting your 18 to 30s, you're likely to need your kidneys for the next 40 to 50 years. And we really need to be working very, very hard to preserve every single remaining nephron they have from the minute we diagnose them and they come under our care. Now, we've known that proteinuria is an important predictor of how quickly people will develop kidney failure with IgA nephropathy. But what RaDaR has shown us for the first time, certainly in a European population, is that low levels of proteinuria are equally predictive and important. So here you can see that levels of proteinuria less than half a gram per day, measured in two different ways here, you'll see in the graph. At 10 years, people with proteinuria less than half a gram a day, 1 in 4 of those people have developed kidney failure. So low levels of proteinuria are important. We cannot ignore low levels of proteinuria in patients with IgA nephropathy. They are identified patients at significant risk of kidney failure. And so we need to reassess how we view a patient with IgA nephropathy. We need to be thinking about kidney failure in the lifetime of our patients, not just 10 years, 15 years, 20 years, the full lifetime of our patients. Now, we are nephrologists, and our job as nephrologists is to save nephrons. If we do not save nephrons, then we are doctors of failure. We look after people on dialysis. We look after people with kidney transplants because we have failed our patients. They have continued to lose nephrons. And so from the minute we get our hands on a patient with a new diagnosis of IgA nephropathy, we need to be thinking about commencing treatments that are going to save the remaining nephrons that patient has, to give them the best chance of avoiding kidney failure in their lifetime. And so what's driving nephron loss? Well, here's a very stylized diagram trying to describe that. So we have, of course, those IgA nephropathy specific drivers that result in glomerular inflammation, scarring, and nephron loss. But of course, once we accrue a significant amount of nephron loss, those maladaptive responses in terms of compensatory glomerular hypertension and hyperfiltration, the impact of proteinuria on the tubular interstitium, the development of systemic hypertension will drive nephron loss in its own right. And so we have to always think, what is operating in our patients to drive that nephron loss? Because that way we can understand how we're going to treat it. So of course it would be great if patients with IgA nephropathy, the minute they started accumulating IgA in their glomeruli, complained, felt unwell and came to our attention. That, as we know, doesn't happen. In most people's clinical practice, patients with IgA nephropathy present by and large by chance. They happen to have had a urine dipstick, they happen to have had a blood test, they happen to have had a blood pressure reading. So when we see patients, typically, they present at this point in the natural history where they have already accrued significant nephron loss. Because when we look at the registries, when we look at RaDaR and we look at other registries, the average GFR at the point of presentation is between 50 and 60 mils per minute, which tells me that patient has already lost at least half their nephrons before I ever get my hands on that patient and are able to intervene and prescribe new therapies. And so we have a very narrow therapeutic window to address this disease in young people. So where did we get to with the KDIGO 2021 guidelines? Well, this is the overarching summary. And what you can see here is the culmination of our 50 plus years of knowledge of how to treat IgA nephropathy and what we were able to come up with. Well, we were able to come up with general supportive measures that really manage those generic drivers for nephron loss that we see in all forms of kidney disease. So try and suppress proteinuria, control blood pressure, use angiotensin system inhibitors, lifestyle modification, address cardiovascular risk. Exactly what we would be suggesting for all forms of proteinuric kidney disease. But where are the drugs that help us treat the immunology, the immune-mediated drivers, the reason that patient has lost nephrons in the first place? Well, actually, we didn't have anything. And for most of my career, it has been particularly bleak in terms of potential new therapies on the horizon. But I'm pleased to say that that's changed, in part because in the KDIGO guideline, we legitimized putting patients into clinical trials of new therapies because we knew they were coming, but also because we had changes to the regulatory landscape. And really it's that latter point that has led to the explosion in clinical trial activity in IgA nephropathy and the beginnings of approvals of new therapies. So this is the work that led to the change in the regulatory landscape, the acceptance of an early change in proteinuria as a marker of how a drug is likely to impact on future kidney failure risk. And this has allowed drugs to be approved earlier, the trials to be shorter, affordable, and this has meant that pharmaceutical industries have been very keen to evaluate their new therapies in IgA nephropathy. So let's think about the treatment of IgA nephropathy. So this is where I'm going to turn things upside down. And it's a shame I can't be there at the actual seminar to see what people think in the discussion, but here we go. So what are our priorities? We need to prevent kidney failure in the lifetime of our patient. We need to address those two drivers of nephron loss, the immune-mediated IgA nephropathy specific drivers, but we also need to accept that most patients present late and will have established nephron loss, and we need to also address those generic CKD drivers that we all know and are common across many forms of chronic kidney disease. And if you look at the right-hand side, you can see the target rate of loss of GFR we are going to need to achieve on average for our patients because they're presenting young and they're presenting late with established nephron loss, and we haven't got that many nephrons. We need to be saving as many of them as we possibly can. And so this is where it gets different to what we've been traditionally doing in IgA nephropathy. I think the first thing we need to do when we make a diagnosis is treat the IgA nephropathy itself. We need to be stopping mesangial IgA deposition. we need to be stopping that deposition leading to glomerular inflammation, scarring, and nephron loss. How do we do that? How do we approach that? Well, I think we need to approach suppression of pathogenic IgA synthesis, exactly like we do, for instance, in membranous, where we want to suppress PLA2R autoantibodies, in lupus, where we want to suppress double-stranded DNA and other autoantibodies, exactly like we do in ANCA, where we want to suppress ANCA autoantibodies. We need to also control any inflammation that's present at the time of diagnosis, exactly like we do in lupus and ANCA. And ideally, we'd like to target those pathways that are triggered by mesangial IgA deposition that are driving that fibrotic phenotype, glomerular fibrosis, tubular interstitial fibrosis. And I'm just going to park this idea very clearly here because we've made little impact on drugs that specifically target those pro-fibrotic pathways. So I'm not going to talk about those anymore. In my talk, it's very much a work in progress. We also, of course, need to think about those generic CKD factors. And this is where I'm switching things around. This is something we also need to consider, but it's not our top priority. Our top priority in IgA nephropathy should be switching off pathogenic IgA, controlling the disease, exactly like we do in membranous, exactly like we do in ANCA, exactly like we do in lupus. Target the fundamentals of the disease, and yes, deal with the impact of existing nephron loss. We should not ignore it, but it should not be the first thing we think about in an immune-mediated kidney disease. And so this is where I think we need to go. We make a diagnosis of IgA nephropathy. Our first thought should be we need to institute therapies to switch off the production of pathogenic IgA. We need to treat the disease. If there is inflammation in the glomeruli at the time of diagnosis, switch off that inflammation. We, of course, need to also assess for evidence of existing nephron loss, which invariably there is because our patients present late. We're going to need to address high blood pressure. We're going to need to address and deal with the impact of nephron loss driving glomerular hyperfiltration and proteinuria. And of course, we need to address cardiovascular risk reduction. These are things we do need to think about, but they should not detract from us treating the underlying disease, the reason this patient has lost nephrons in the first place. So let's think about how we might reduce pathogenic IgA production. We can go for a B-cell depletion approach, or we can go for a B-cell modulation approach. Exactly like we think about ANCA vasculitis, lupus nephritis, membranous nephropathy. The drug we would commonly use to deplete B cells is the CD20 approach with rituximab. We've tried that in IgA nephropathy and it didn't work. It didn't reduce abnormal Gd-IgA1, it didn't reduce immune complexes, it didn't impact on proteinuria or GFR. What that's telling us is that the B cells and plasma cells responsible for producing pathogenic IgA are likely located in a different microenvironment than those that are generating autoantibodies in ANCA and lupus and membranous. And that fits with the fact that the other drugs that we use in those diseases equally don't work in IgA nephropathy. Cyclophosphamide, azathioprine, mycophenolate, very mixed evidence that these drugs are effective, completely different to those classical autoimmune diseases. There are other depletion strategies that are being tried. We've got 2 phase 2 trials of CD38 depletion, which specifically targets plasma cells. And hopefully we'll have that data later this year. But we don't have data yet. A lot of interest in B-cell modulation. And the first approach is to target the production of pathogenic IgA within the mucosal immune system of the gut. And there's a drug called Nefecon that is specifically designed to release the steroid budesonide within the terminal ileum, where there is a very high concentration of mucosal IgA producing plasma cells, with the idea that you can suppress the activity of those cells, reduce mucosal IgA production, which in turn will reduce circulating levels of Gd-IgA1, immune complex formation, and therefore mesangial deposition. We've had a phase 2 study that showed that targeting the gut mucosal immune system did lead to a dose-dependent reduction in proteinuria. We've now had the NefIgArd phase 3 trial report both its 9-month proteinuria data and its 2-year GFR data. And I'll talk about those in a second. And we've more recently published a biomarker paper looking at the samples from the phase 2 NefIgArd study, clearly showing that this approach reduces the abnormal form of IgA, Gd-IgA1 in the circulation, reduces immune complex levels, and modulates the mucosal immune system in terms of the various chemokines and cytokines involved in maintaining mucosal health. So the NefIgArd trial was a trial of 9 months of Nefecon with a 15-month follow-up period, and what we saw in that trial was a suppression of proteinuria and a preservation of GFR. That reduction in proteinuria did relapse after stopping the drug, which tells us that this drug is not curative as a single treatment cycle. It also tells us it's not irreversibly damaging the mucosal immune system of the gut. What it does mean is that we're likely to need repeated cycles of this therapy. And you can see in the middle panel that GFR is stabilized while the patient was on the drug, but when the drug was stopped, the GFR began to decline, as you might expect without active drug in the system. Now, the good news is that this drug is well tolerated with minimal systemic steroid effects because of high first-pass metabolism by the liver. And so it is acceptable, in my view, that we might well be using repeated cycles of this treatment over the longer term to suppress pathogenic IgA production within the gut. We have data from an open-label extension study that's going to be reporting at some point this year, which will tell us really in great detail what happens with the second cycle of this therapy. But there are other ways to modulate B cells, and an area that's getting a lot of interest at the moment is in inhibiting BAFF and APRIL signaling. These are two cytokines important in B cell proliferation and survival. We have 5 different drugs currently being evaluated in IgA nephropathy. We've got early data from phase 2 studies that looks incredibly promising. We've got data on sibeprenlimab, which is a monoclonal antibody against APRIL, and we've got data on atacicept, which targets both BAFF and APRIL. So here we have the data on sibeprenlimab, which shows a significant reduction in proteinuria with treatment. It suppresses Gd-IgA1, and GFR appears stable during the duration of the phase 2 study, albeit smaller numbers and shorter term follow-up, but very promising information. The drug was well tolerated. We've just published the data from the phase 2 atacicept study, and again what we see here is a significant reduction in proteinuria, significant reduction in Gd-IgA1, and in the initial 36 weeks, stabilization of GFR. What's exciting is when we work out now to week 72, we can see that those patients continually exposed to BAFF-APRIL inhibition had completely stable GFR. They did not lose kidney function, whereas the placebo group were losing significant kidney function over the similar time course. We can see suppression in proteinuria, and in these graphs you can see there was an initial double-blinded 36-week period, and then all patients, including the placebo, were swapped onto 150 milligrams of atacicept. So you can see that proteinuria fell, Gd-IgA1 fell, and GFR stabilized. So how might we think about reducing glomerular inflammation? Well, the way we have reduced inflammation across all forms of disease over the past 30, 40 years is to use systemic glucocorticoids. And we've used them in IgA nephropathy. They clearly are a very good anti-inflammatory, but just like any anti-inflammatory, when you stop them and you haven't altered the fundamentals of the disease, the inflammation comes back and the disease comes back. And that's exactly what you see in the testing study. You see that suppression in proteinuria as a biomarker of inflammation over the first 6 months. When the drug is stopped, the inflammation just comes straight back, and you see the proteinuria relapsing. That wouldn't be a problem if we could give lifelong glucocorticoids or we could give repeated cycles, but we know these drugs are incredibly toxic and patients dislike taking them. The data from the IgA studies really reinforces what we've known for many, many years. There's an increased risk of infection, there's an increased risk of metabolic complications, there's an increased risk of damage to bone health, there's an increased risk of cardiovascular risk factors such as gain of weight, glucose intolerance, hypertension. Perhaps underappreciated is the impact on mental health. And this study here clearly reports that in patients given systemic doses of glucocorticoids, there are significant changes in mania and depression scores very soon after starting these therapies. The hope is that we will be able to manage inflammation by avoiding glucocorticoids with complement inhibition. And there are multiple drugs targeting multiple proteins in the complement cascade currently being evaluated. We have data now from phase 2 studies of C5 inhibition and factor B inhibition. And indeed, the data for factor B inhibition looks particularly interesting. This is the phase 2 data of iptacopan. And particularly interesting on the right-hand panel is the fact that we're seeing reductions in complement-related biomarkers in the urine that potentially may help us guide therapy in the future. We had the data for the phase 3 proteinuria 9-month readout presented at the World Congress showing a significant reduction in proteinuria, and it's likely that this drug will be approved for the treatment of IgA nephropathy in the United States before the end of the year and likely to come to Europe next year or the year after. We need to think very much about, in those patients with established signs of nephron loss and CKD, managing the things that we've always managed in IgA nephropathy. How do we achieve that? We achieve that with lifestyle modification. That's easier said than done, but we know it's important. The use of renin-angiotensin system inhibitors. We now have data on SGLT2 inhibitors in general CKD, and certainly data from DAPA-CKD and EMPA-KIDNEY suggests these drugs work very similarly in IgA nephropathy patients as they do in the general CKD population. We now have information on dual endothelin and angiotensin receptor antagonists, specifically sparsentan from the PROTECT trial. We have 9-month data and full 2-year GFR data now. What this shows is that if you add endothelin receptor antagonism on top of renin-angiotensin system blockade, you get additional proteinuria reduction and preservation of GFR. And this approach is well tolerated, the major side effect being hypotension. We're going to have potentially endothelin receptor antagonists coming on the horizon, such as atrasentan, and that data will be reported at the ERA in a couple of weeks' time. And then we have a whole range of other drugs that are being tried in non-diabetic CKD that may well also be drugs we can use in IgA nephropathy. We know none of these approaches stop the production of pathogenic IgA, but they may positively impact on glomerular inflammation, certainly from preclinical models. But I think we do need more data to confirm that they truly have an anti-inflammatory effect. And so this has been the situation managing IgA nephropathy for most of my career, going to the drug cupboard and it being bare. This is the situation that's coming in the very near future. Lots of different drugs available, likely to be very expensive, targeting pathways we've not targeted before as nephrologists. How on earth are we going to think about using them? So here we have everything, an approach, I think, that allows us to think about treating this disease with the drugs that we currently have available in green: Nefecon, systemic steroids, SGLT2s, sparsentan, RAS inhibition. Those in grey are things that we may have in the near future. I think this approach is going to be equally relevant to recurrent IgA nephropathy in the renal allograft, and I think also in IgA vasculitis with nephritis. I think the next 5 years are going to be incredibly exciting, and we're going to need to think about our approach to this disease. And I think we need to turn things on its head. But I'll be interested to see what my panel members think of what I've just said. So thank you for listening and enjoy the discussion.
So thank you very much, Jonathan. This is a very exciting talk. I think that we were convinced that we have experienced the empty cupboard and that we have more options. We have received questions earlier, and the first question was, I think that Jonathan showed convincingly that improvement of proteinuria in IgA nephropathy as showing clinical benefit in IgA nephropathy, and this is what has been really the step moving forward in all these clinical trials that we look at proteinuria or albuminuria outcome in these patients, and that's very significant. But what we have lacking until recently is other type of biomarkers, which I think that we'll see will be more prevalent when we have more information on these complement levels in urine and things like that. So since Jonathan is off the hook and we can't ask him questions, we have this excellent panelists instead, and I wanted to ask you and try to convert this discussion into the clinic. We have many options, but what can we do now, and what have you done in cases in your clinic? So I'll start with Claudia Seikrit to discuss a few cases from your perspective in your clinic and what you have done or what you perhaps would do with them in the future if you had the possibility.
Yes, thanks a lot, Annette. And yeah, I think we heard just a great talk from Professor Barrat, which is presented nicely all the amazing possibilities which are upcoming in IgA nephropathy in the near future. Today I prepared a little case from my clinic, which I would like to present you. And it was a male 26-year-old patient who changed his work one day and had to go to the medical service of his company for a checkup. And what they found was high blood pressure, amount of proteinuria in urine dipstick, which was positive, and hematuria. So he was referred to a nephrologist who decided, of course, to do a kidney biopsy. His eGFR was 100 at this moment, with a proteinuria of 1.1 gram per day. And yeah, kidney biopsy was performed, and yeah, as we can imagine, it was an IgA nephropathy with an M1, E0, S1, and T1 score, in the MS score. So what the nephrologist did was, of course, he started treating the patient with an ARB and treating hypertension, and titrated it up to the maximum permitted dose. And as expected, proteinuria fell down to 400 milligram per day, and everybody was quite happy. Then he was diagnosed already 7 years ago, and over the years he developed more and more problems with his blood pressure. So the doctors started other medications using beta blockers and calcium antagonists. And 7 years later now, he was referred to my consultation because he had again a proteinuria of 1.7 gram per day. And at presentation, there was a young man in his 30s who had a BMI of 32. So he had an overweight, and blood pressure was not controlled, with blood pressure values from 130 to 140. And yeah, I wanted to discuss with you what you would have done, and finally report what happened to this patient later on.
Yeah, all right. So we are all religiously following the KDIGO guidelines, and we are very stuck on this supportive care. But I have read actually many studies where it's they're not really used as they should. I mean, these I'm always surprised that in many cases still people don't use the ACE inhibitors or ARBs, or if they're hospitalized for some reason, they are taken out and they're never put back. So I think that that's of course a very important basis. We need this basic treatment. But so this patient didn't have any really crescentic picture or anything. It was just like normal IgA nephropathy.
Yes.
So
exactly.
I would probably have done what you did until the patient showed up the second time with significant proteinuria again, and then you get to tell us what your thoughts were at that point.
Exactly. At that point, in fact, I felt that there was still room for improvement. So I was hesitating in putting him directly into a clinical trial to offer him one of the new treatments. But he was a little hesitant because it would use a lot of time and during his life. He has a young family, so that was a problem. So we made a compromise, and I said, okay, now we can try during several weeks to improve the supportive care, which meant I started an SGLT2 inhibitor, which he didn't have at that time, which is kind of standard of care until up to now. And I also changed his blood pressure medication and stopped the calcium antagonists and added a diuretic. And what I also did, I talked a lot, and it is quite painful, but I talked a lot to him about lifestyle and about reduction of salt intake, about losing body weight, and about losing not eating too much proteins, and having a healthy lifestyle. And he was quite impressed because for a long time nobody had advised him like that. And he said, okay, I'm motivated, I will try. Then we said, okay, we meet again in 1 month and we see what happens. And he was compliant. And to my big surprise, he reduced his body weight in 1 month, about 2 kilograms already. Probably it was also because we started the diuretic. And he stopped eating salt, which lowered his blood pressure from the levels of 130 to 110. He felt not good, there was no dizziness. And he was motivated. And by this change of lifestyle, he already had a proteinuria reduction down to 0.25 gram per day, which was quite significant in mine. So I said, okay, then let's continue like that and see what happens if we go on with this strategy. And when he came back 3 months later, he lost 10 kilograms of weight. He continued his healthy diet. He started doing sports. Blood pressure was well controlled in the 110th. And then he came back in 4 months after we started this kind of intensive, really intensive supportive treatment with a proteinuria of 0 without any hematuria. And I think this is one rare, but it is an example of how strong this supportive care, which we all know can be for some of our patients.
Yeah, thank you. I think we can draw the conclusion he should have met you much earlier. That would have been a good intervention. Yes. Then I would like to ask Gema if you would like to present a case from your practice. I don't know, we can't hear you. You're muted.
Okay.
Okay.
I would like to present a case that an admit situation because this kind of patient are out of all the clinical trial. Is the patient with a rapid progressive IgA. It's almost 1/3 of the cases of IgA present like a rapid or very progressive IgA patient with an important crescent in the renal biopsy. I don't have a very specific case of my clinical, but it's a real situation. I would like to share with you which is the most optimal approach for this kind of patient, because of course budesonide in the clinical trial of budesonide this kind of patient is out, and in all the clinical trial it completely out. So the possibilities that you can use maybe prednisolone or prednisone in monotherapy, prednisone with cyclophosphamide, or prednisone with what else? I don't know, what is your opinion?
For rapid progressive glomerulonephritis, that's really crescentic. I think we think more like a vasculitis, you know, they have a bad prognosis. I think maybe in the future we'll be able to use complement inhibitors, but right now the companies don't really promote this kind of studies. And I think that would be also very interesting in relapsing IgA nephropathy in kidney transplant patients that may have a bad prognosis if the disease is very active. So I, like the old times, I would use prednisolone for these patients, also the ones who have more this minimum change phenotype with lots of proteinuria. But depending on how crescentic it is, if it's lots of, you know, very really crescentic glomerulonephritis, I would use depending on the age of the patient and if they want to, you know, pregnancies and things like that, I would use either cyclophosphamide or rituximab to control the inflammation. So that rituximab didn't work in IgA nephropathy, it has been shown, but we have data also from several European cohorts with IgA, crescentic IgA and also IgA vasculitis that rituximab seems to have a pretty good effect, which is maybe not so surprising because it's more similar to very inflammatory diseases. So that's what I would do. What is your experience in general with these drugs at your center?
In my we usually use the percentage of crescents in the renal biopsy, because when a heart include the percentage of crescent in the OS4 classification, when the percentage was above 25%, the probability of responding was very, very low. So if the percentage of the crescent is above this percentage, we don't treat it, even when it's very painful for you to see the patient, to see the glomerular filtration decreasing, and don't do anything. But I think is to avoid unnecessary adverse events, because the immunosuppressive treatment in this kind of patient is don't add anything good.
Mm-hmm. Yeah, so I think I probably agree. I think Claudia, you had some similar case with the more crescentic picture, and what would you do?
Yeah, very recently we had a really crescentic IgA nephropathy with an RPGN course patient who was followed by his doctor. So we knew how the creatinine values were some months ago. So we knew that there was a more than doubling in creatinine values, and it was really a rapid course. And we treated, as you proposed, also with rituximab, because she's of childbearing potential. She wants to get pregnant, and we started in treating her like an ANCA-associated vasculitis with an initiation and a maintenance therapy. And during that course, I wondered if rituximab would be enough to really stop the progressing IgA nephropathy, because she improved nicely from the crescentic disease, I would say, but 1 year after the first dose of rituximab, she still had 1 gram proteinuria. And I was wondering if then rituximab is potent enough to, knowing how the clinical trials were, to stop the progression of IgA nephropathy. And I wondered if I should add budesonide additionally to the rituximab maintenance therapy to improve the disease.
Yeah.
But we have a clinical trial that show that rituximab is not useful in the IgA. Of course, again, the extracapillary IgA are out, but rituximab is a very bad drug if you want to deplete the B cells in the mucosa. So the rituximab deplete the B cells in serum, and is a very good drug for that, but it's a very bad drug to deplete the B cells out of the blood. So in the IgA nephropathy, when the problem is the IgA in the intestinum, in the mucosa, I think the rituximab is not enough, at least in general. Of course, we can have a case where the rituximab works, and perfect is the very good news for you, but in general, I think rituximab in IgA nephropathy, not IgA vasculitis. Maybe in this case, we have to discuss other issue. But in general, in IgA nephropathy, rituximab, I have a deep doubt about its utility.
Yeah, I think that we will, use whatever we have available, but I think what is pretty clear is that we need a combination of drugs, and there are different mechanisms. So I think that the patient still has the significant proteinuria. That's sort of a bad prognostic factor. It remains bad prognostic factors, and you have to do something about it. And if you can, you're possible for you to use budesonide, which is not possible to use in all countries, that would maybe be a good option, or try to enter the patient into a clinical trial. So now I think I will move to some of the questions from the audience, and we have questions that we received ahead of time, and also some questions in the Q&A. So we'll have this question about hydroxychloroquine in IgA nephropathy, if there's any use for that. And Gema, do you want to comment this question?
Yes, Dr. Barrat, tell us that now we are going to have a lot of drugs to use for IgA nephropathy, but maybe the price of the new drugs has been a very important issue to treat. And hydroxychloroquine is good, cheap, and available. And currently, I remember at least one clinical trial had shown that hydroxychloroquine is good for the IgA nephropathy. This drug achieved an important reduction of proteinuria when the patients were treated with this drug. So I think hydroxychloroquine should be a drug to be in mind when we have a patient with IgA and proteinuria. I think that's a very good opportunity, and maybe we need a bigger clinical trial to address this drug.
Yeah. So I just want to comment that some studies have been done in certain populations and not in other populations. So there is like this tonsillectomy has been shown to have some effect in the Japanese population, but in no other populations. Mycophenolate has been shown to be possible and have some effect in the Chinese population, but in no other populations. So there is this also question of the genetic background probably, and that the disease may be different in different populations. So we need to have these studies also to confirm findings in like a Caucasian population and from different countries. So just a question from the audience about that we now have more options treating early IgA nephropathy patients. Would there be a role for screening through urine dip like they do in East Asia? Do you have any thoughts on screening? Because as Dr. Barrat said, many of these patients show up, they've probably been sick for quite a long time. Is there any way we can find them earlier?
I think that screening programs would be really helpful in this case, but at least in our part of the world, not really established for young people. It's rare that we have a urine dipstick for young people if it was not for a medical examination when they started a new job. So it would be definitely something that would help to earlier detect patients with IgA nephropathy and treat them earlier before nephrons are lost. Sure.
Right. Yeah, I'm not sure exactly how this would work, but I guess you could have, you know, there is this method of finding blood in the stool that you send those little things to people at home. They can send a stool sample and then they will find, you know, and then they can screen them for colon cancer and things like that. But I think we'll see what happens if it, but since IgA nephropathy is much more common in East Asia than in our countries, we'll see if that comes to fruition. But we would like to find these patients early. So then we had some other questions about the role of SGLT2 inhibitors and sparsentan, this new more type of hemodynamic drugs. What would that be in IgA nephropathy? Do we treat all patients? Gema?
Claudia has presented us ideal case about this question. Sometimes the proteinuria can decrease only with non-immunological treatment. With the SGLT2 can reduce very significantly the proteinuria and put the patient in a safe situation from the point of view of progression, of renal progression. Of course, the SGLT2 is a very good drug to achieve a decrease in the proteinuria. We can see in the clinical trial, and now we have experience in our real clinical, in our daily clinical practice. So, of course, I think the SGLT2 is a very good drug to decrease proteinuria in IgA patient. Sparsentan, I think it should be a very good drug too. The clinical trials show very impressive result about the decrease of proteinuria. Maybe medium result about loss of glomerular filtration, only 1% per year of reduction of glomerular filtration. But I think the sparsentan will be a very good drug too in the real clinical practice. But we have to know. The problem of sparsentan is the price, because I don't know if the same effector should be the same price, but maybe the sparsentan is going to be higher in the price that the other drugs, the other hemodynamic, non-immunosuppressive drugs in IgA nephropathy.
Thank you. So one question is when we should then use these complement treatments once they are approved, and they seem to be quite successful, and also the duration of treatment of complement inhibitors or modulators. And maybe I can answer that, is that we don't know. But we need, we are happy that they're coming because they seem to be important. And I think that we will have to rely more on biomarkers that are not, or you know, perhaps not available now, but they will, through the studies, they will come up with biomarkers, and then maybe we can treat them as this was discussed with budesonide for, you know, repeated cycles based on perhaps a biomarker set that we could use as prognostic marker in addition to proteinuria. As we discussed before the seminar, is how often do we do rebiopsies, and we don't really do many rebiopsies. We're happy to have the biopsies so that we have the diagnosis, but with the new treatments, we may have to do more rebiopsies to see what exactly we're treating. So then we had a question for both of you. That would be a case, the best treatment for 30 to 50-year-old with IgA nephropathy, CKD 1 to 3b, and proteinuria range 1 to 3 grams, that is non-nephrotic proteinuria, with or without red blood cell counts, in your opinion. So Claudia, if you want to start.
Well, besides, of course, the optimized supportive care, I think I would think about treating him either with budesonide, if his concomitant diseases allows that, for example, if he is diabetic or not, or with sparsentan. And maybe in the future, why not combining them? Of course, we have no data today who will support that, but that could be an option. And I think I would certainly not start thinking about systemic corticosteroids in the first way, fine, at the first, but prefer rather the treatments which have less side effects.
I fully agree with Claudia. In my opinion, maybe the presence of hematuria it's important. Maybe when the hematuria is present, maybe I tend to start the immunosuppressive treatment before, and when the hematuria is lacked, maybe in this case I try to do harder with the conservative treatment. Maybe in this case I can wait for a long time to start immunosuppressive treatment, and of course budesonide could be a very good option in this scenario.
Yes, I think we all want to move from systemic glucocorticoids in general for most of our diseases, but sometimes we still use them. So I have a question for both of you. Do you believe that there's a place for all the new medicines coming in this area? Or are we going to be overwhelmed and not know what to choose?
I think there might be a place for all of these new drugs coming, because we have very different patients, and there might be drugs which suit better to some of the patients than to others. Of course, we will need to find methods, as you already mentioned, to figure out which patient will improve most under which treatment by biomarkers, which will certainly be coming in the next years and which will be important in the setting. But I think that there is a place for these treatments.
The problem is when we don't have any treatment. But if you have a bunch of treatment, you only have to choose the best option for your patient. I think the high number of drugs is a very good news for us.
Yes, and then there will also be this aspect of the cost, because many of these drugs they're very expensive, and that's one of the reasons was Nefecon, which is budesonide specifically for IgA nephropathy, is not available also in several European countries. So we will see what happens there. If there will be competition, that means that the price will go down, but that may be more in the long term. So I think the most impressive data that was shown early by Professor Barrat was this graph over the radar study, what happens in the UK, this registry study, that patients that are diagnosed with IgA nephropathy before they're around age 40 will all end up needing dialysis or transplantation. And that's a thing that we really need to consider. We have to think about the lifetime risk of these patients. And sometimes Professor Barrat says that we work as a nephrologist for 30 years, and then, the patient will see somebody else after 30 years. But we need to take that responsibility now to really protect the kidneys, both the inflammatory component, but also the CKD component. And with that, I want to, we're getting close to the end of this e-seminar. And if you have any final points or considerations, Gema and Claudia, before we end.
So I quite agree with you, Annette, that we are facing to a new era for the treatment for IgA nephropathy. we will have new and very novel drugs for this glomerulonephritis, but we need more and especially better biomarker to know which is the best treatment, in which time is the best time to treat the patient, and for how long you have to maintain the treatment. Because in ANCA vasculitis, in lupus, we have bad biomarkers, but we have some biomarker, ANCA, DNI, complement, but in IgA, even the renal biopsy is not a very good biomarker. So, of course, I think the good news is we are going to have new drugs, but we have to learn how to use it.
Thank you. And Claudia, the final words?
I absolutely agree. I think that it will be crucial, as Gema said, to find biomarkers that will help us guiding therapy in the near future, and that we are looking forward to exciting times in IgA nephropathy, and that this is a positive time for all our patients, and we are glad participating in these times.
Perfect. Thank you very much, Gema and Claudia, and also Jonathan, even though he's not here with us today. And I want to thank the audience for the attention and participating in this talk today. And thank you for all the questions.